Here's a case I want to show you that was one that I saw while I was on call, and the history provided was jaw problem after seizure. So take a look at this scalp radiograph and you can see that the mandible looks like it's anteriorly positioned. The lower teeth are out in front of the upper teeth, which can occur in malocclusion, but you'll see in a moment why it occurred in this case. So I wanted to make sure there was no fracture, and I was scrolling through, and there was no fracture. Take a look at here. You've got the temporomandibular joint here on the right, which is empty, and the temporomandibular joint here on the left, which was empty, and the condyles are anterior to the temporomandibular joints. Let's take a look at this on sagittal imaging. Again, you have the condyle anterior to the joint. This part of the temporal bone is the articular eminence, and the condyle really never should be out in front of the articular eminence. It may go down below it when it translates down the eminence during opening, but it's not usually out in front. And in this case, this was again a bilateral anterior mandibular condylar dislocation. So what's going on? Why did this happen? We know the patient had a seizure, but exactly why did the condyles dislocate anteriorly? So let me take us back to the axial. There are four main muscles of mastication: the masseter, the medial pterygoid, the temporalis, and the lateral pterygoid. And only one of those muscles opens the mandible and pulls it kind of down that articular eminence anteriorly. And that muscle is the lateral pterygoid muscle. So first let's find the pterygoid plate. So there's the lateral and medial pterygoid plate, and the lateral aspect of the lateral pterygoid plate is the attachment site for the lateral pterygoid muscle. So right here, this muscle that in this case is going from the condyle to the lateral pterygoid plate, that is the lateral pterygoid muscle. Now usually it is more in this orientation because normally the condyles are back here, but you can see that it is the contraction of this muscle bilaterally that pulls the condyle forward and normally opens the jaw, but in this case dislocated the jaw. Let me go back to sagittal. That concept actually explains the treatment options for a patient who has recurrent dislocation. So this case obviously was due to the seizure. Some cases are traumatic, but many patients get recurrent bilateral or unilateral condylar dislocation, and there are multiple treatment options. So one of the options is to steepen the articular eminence so that the condyle wouldn't be able to slip out underneath it. So lengthening the articular eminence is one treatment option for recurrent dislocation. The other treatment option is to just kind of chop off the articular eminence to make it short, such that if the condyle did move out in front, it would easily slip back. The other treatment options actually involve treating the lateral pterygoid muscle. People do a lateral pterygoid myotomy and cut the muscle to reduce recurrent dislocation, and some surgeons will also do Botox injection of the lateral pterygoid muscle. So again, this case demonstrates bilateral mandibular condylar dislocation in the setting of a seizure, and it highlights one of the muscles of mastication, the lateral pterygoid muscle, which attaches on the lateral aspect of the lateral pterygoid plate and inserts on the condylar head and brings the condyle forward and down the articular eminence for normal opening. But in some cases, in patients with recurrent condylar dislocation, it can bring the condyle out of the temporomandibular joint.